This podcast is intended for educational purposes only and is not medical or legal advice. Always follow your local policies, procedures, and protocols when functioning in your respective profession. Additionally, the views expressed by the speakers and owners of this podcast are their own and do not represent the views of their respective employers. Listener discretion is advised.
Alert Medic 1 response.
Hey everybody, welcome back to the Alert Medic 1 podcast. So you got myself, Josh, and Cody today. We're going to be talking about airway training mistakes that are common and maybe some pitfalls of that and how to overcome it and then start to master your airway training program. So Cody, if you want to lead it off and we'll just go from there.
Yeah, so I have the privilege of getting to go around the country and train folks with airway management, get to go around the state, training folks with airway management, and even the privilege of teaching new or being present, when we're teaching new paramedics airway management stuff. And what I see is not a lot of student problems. I see a lot of I guess what gets under my skin about it, or what prompts the topic of the day is I see a lot of poor teaching habits, poor training habits. I've kind of codified it at about 5 of them, and I think we can go. Gosh, we could probably go to 20 or 25, right, Josh? Of just it's just mistakes. I don't want to say that this is absolutely the wrong way to do it, with a couple of exceptions. But let's just kick it off. The first mistake I notice is when we come behind an instructor or a training program to come in and bring our own to them. We see a lot of instructors that teach the way they were taught, and this was something that Moose highlighted to me on several different occasions, where I was kind of like, man, why are we doing this training evolution that we know is wrong? Like, for instance, I don't know, you walk into your simulation lab and there's a pile of desks, in the middle of the floor, and there's Fred the Head stuffed under there with the sole purpose of intubating it. And I'm like, well, why are we doing that? And it's not bad instructors. I don't think that. I don't think the instructor themselves are poor. I think it's just they were teaching what they were taught. Does that make sense?
Yeah, it does.
Kind of teaching the same nonsensical and using some of the same nonsensical platitudes that they heard, as well. And what do you think are some of those things? What are some of those things that I hate to say old school because it kind of singles out a population of folks, but what are some of those mistakes that you see as far as teaching the way they were taught?
So one of them is, and everyone's guilty of this, by the way. This happens in every program. And it's hopefully it doesn't stay this way through your program and that you evolve your training, but it's putting Fred the Head on the desk, on top, not under. You put it on top, and everyone is intubating from a standing, bent over at the waist. They're not at their knees or in a captain's chair or putting the head on a stretcher. And I don't want to emphasize so much, having everyone get down on the floor, elbows on, classic DL maneuvers, but incorporate things, make it as realistic as possible while using the low fidelity mannequin heads that we have. Mike talks about all the time that you don't have to have high fidelity trainers. You can take low fidelity and get great training experience out of it by engineering what you have to simulate it best. You don't need the $40,000 sims that breathe and talk and everything to simulate intubation. Are the salad mannequins a little bit on the expensive side? Yeah, but they're more low fidelity and they do simulate a bunch of things. But engineer your training scenarios to best prepare your students to actually execute in the field. And first thing, obviously we might want to just start them on the table, but you work down to maybe a mat, stretcher, getting them so that they are working in the position that works best with the equipment that you work with. And I understand that not all programs are in-house programs, that the community college programs where you have 2 people from one jurisdiction, 2 people from another agency, 4 from maybe that host county agency, whatever it is. So you may not have the exact tools, but make things to best prepare them to use those tools, or encourage them to bring some of those training items to class so they can train on what works for them and where they're working. Sometimes these people go on to other jobs where they use other equipment, but if you at least instill these fundamentals with DL and VL, most of it transfers.
Yeah.
And you can pick and choose parts from each one. So like Mike's most recent podcast was all about, or segment, one of his most recent ones was about intubation, and talking about the McGrath blade. So the McGrath is vastly different from what I use, the AirTrack.
Mm-hmm.
And I know what he said about AirTrack, and I have my own feeling. My coworkers have our own feelings about AirTrack. But you can take aspects from learning AirTrack or King Vision, which are very similar,
Quite.
and take them into other types of video learning scopes like that. And the McGrath, same thing, is much like the UE scope and a couple others out there. And in fact, I'll say DL transfers to McGrath and UE more than it does AirTrack and King Vision.
Mm-hmm.
But if you don't provide these tools, then they have nothing to work off of. And then when they get to these tools, it's like back to square one.
Yeah.
But I think I went a little bit off topic there. But
well, no, you highlighted some really great stuff. One of them was, so I used this paper in a different presentation about simulation and training last week, and it comes from the JSOM from the 2017 summer 2017 edition, and it talked about basically low fidelity, well executed low fidelity training is just as good as high fidelity training, to paraphrase some Max Dodge too. And what this paper says specifically about HPSs was generally the skills most valued by participants, those educated via the mannequin HPS, coincided with those difficult to practice but life-saving measures such as Crike responses to massive arterial hemorrhage and wound packing and extremity tourniquets. So the features that device manufacturers have aggressively marketed, including pre-recorded sounds or streaming audio, automated movement of the pupils, the limbs, are less valued by the end user group. So we want mannequins that can respond to, or we want trainers or simulators that will respond to the procedures that we're trying to practice, instead of a bunch of nonsense that just costs tens of thousands of dollars.
Yeah, not to go off on topic of the high fidelity stuff. So we have 2 in our paramedic education program. We use one is more broken than the other, so one really gets used a whole lot.
One's the difficult airway trainer.
But I used the crap out of them last year. Honestly, I usually pick that one. I was pretty familiar with the controls and what it could do. The most I did, honest to God, was maybe some airway, some lung sounds, but it was mostly pulse, blood pressure, and that was correlated with a sim pad for the monitor. That wasn't so much even them, actually doing a blood pressure, actually, palpating and pulse. They were, but at the same time, that's all I was really using it for. So we can simulate all of that easily with much more low fidelity stuff. But it's making sure that we set things up, use other tools. So sim pads, iSimulate, not to call out a specific company, but the one that a lot of people use, to take a low fidelity training situation and make it a highly engineered situation.
Well, you could take a human being, right? We did this in Austin. You could take a human being with, and we use the iSimulate software, and make them with a couple of props, a really high fidelity simulator. And it's pretty funny to see the looks on people's faces when they walk in the room and they see a person sitting there wearing like an LVAD vest or something, and it's like they immediately like have this epic case of swamp ass, and like, oh my god, I feel like I have to do this for real, kind of situation. And it's
Our 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 ALS credentialing uses actors.
mhm.
It's the best simulation you're going to get, honestly, with a lot of the stuff. But
I think so.
yeah,
To reel us back on to get us back on track. Some of the things that I see are just their habits that they were taught, and they don't really know why they're doing it. Like teaching airway management as a single provider skill, and we test it that way too, right? The EC technique with the BVM, the intubation thing, the whole package, the whole procedure is done as if you're the only person there that can do it or that can do anything to the patient. And you and I and everybody that's listening to this knows that is that would be such a rarity in a couple of operational contexts that I can think of where that would be the case. But you would still have somebody that could, turn knobs for you, hold a seal, squeeze a bag with you coaching them, or something like that. So that was one thing, and the other one was holding your breath while intubating.
I remember
Oh,
that one from medic school. Yeah.
I'm like, why do we do that? Well, in case the patient, we shouldn't have any more than 30 seconds or any more than 30 seconds of an attempt. And I'm like, well, why do you say that? Well, the patient will desat. Well, not if you pre-oxygenate them, they won't. Like the whole reason we teach pre-oxygenation now, which is another kind of a bullet point, the whole reason we teach it the way that we teach it now is so that we buy apnea time, so that we don't have to do that. Now, it doesn't mean you can just indefinitely dig around in somebody's airway trying to get a tube in place. But it does buy you a margin of safety so that we don't have to do that. So what I think when I hear that, I was taught this, was perhaps the instructor could use an update, right? Which speaks to another issue that there's not a ton of airway management update training out there. There's really not. At our level, right, at the paramedic level and the critical care level, you basically have, I'm sorry, the flight level, you basically have what the organization's offering you, and that's it. There's a difficult airway course that's out there, or some maverick that's out there doing his own thing, as far as airway training. And this is something that is a gap that we try to fill with cadavers and whatnot. But we still see these things being perpetuated. 20-year, 30-year medics that are still burying the blade all the way into the mouth and then backing out until the cords drop into view. I have to wonder, like, how often are we practicing these things? How up to date is our practice? So teaching the way we were taught, or teaching what you were taught the way you were taught, is one of the more glaring things that I've seen out there. And this is a coast to coast kind of issue. What do you have to add to that, man?
So I think part of it is that this is not a high use skill for a lot of us. Okay. While we kind of hold it beholden, we definitely hold on to innovation as a paramedic skill. It was a major topic of discussion with Henry Wang's articles and part in Airway's trial, that felt like they were kind of going after it, trying to take it from us, but they weren't. Okay, we'll just put that out there right now. They weren't coming for it. Okay, but we hold on to this thing. But a lot of us, that might be a little bit too hard to say. There are those of us that don't look at progressing it, because at the same time, while we have it beholden, it's not something we do every day. There is a small percentage of paramedics that are intubating on the regular. And when I say regular, I'm going to go with once a week. Let's just say that's regular. Mike even said, when you look at the numbers, even the most experienced paramedics in intubation don't even come close to anesthesiologists or CRNAs,
Mhm.
stuff like that. People that are dropping multiple tubes a day in inpatient and outpatient scenarios.
Right.
We can call ourselves experienced, but we're not really. And not until a lot of us acknowledge that, I think, are we going to notice, like, hey, maybe we need to actually pay attention to this and understand what I need to do better. And then we all are teachers at some point.
Mhm.
We all teach a new person, whether it's a student, a new medic. We're just talking at the kitchen table with new providers around us, stuff like that. That we need to stay on top of it and understand what is the best practices. To kind of bring up what Cody brought up with the old school medic burying the blade and then coming back and letting the cords chop. We need to know what progressive laryngoscopy is. We need to understand that it's a measured approach. It's aggressive, but it's measured aggressiveness, not to bring up a previous episode title. But we need to understand that there is a proper way to do all this. There is a whole sect of medicine that specializes in this, and they've been doing stuff like progressive laryngoscopy for years, and it's
Mhm.
now just starting to hit us, and it's because we have video laryngoscopy. But you can do it with direct, by the way.
It's
You can still do it
encouraged.
direct. Yeah,
It's
because
absolutely encouraged.
you're going to place the tip of your blade in the right spot more often than not if you understand what you're looking at going through. And it just opens the door to things
Yeah.
like the salad technique or any kind of airway decontamination via suction. You want to call it salad, you want to call it something else, whatever it is. But you got to be able to see what you're looking at. And that's another thing, that to crush an old myth, we already crushed a little bit, the 30-second or the holding your breath while you intubate. Bad
Mhm.
idea anyways. But the 15 seconds of suctioning. I know I was taught it. Cody, you were taught it. I'm sure a lot of our listeners were
I
taught
didn't
it.
even think about that, man.
And unfortunately, a lot of our listeners probably were still taught it within the past 5 to 6 years.
The National Registry standard is 10 to 15 seconds, which I don't get it.
Yeah.
It's going to take you a little bit of time to clear an airway.
Exactly. So, like, we can suction continuously
Mhm.
throughout our attempt, especially if you pre-oxygenate. I feel like I'm starting to just go into an airway talk instead of an airway training talk. But
it all matters.
Yeah, it all matters. It does all matter.
Well, I think because what you're hitting at,
I think a big part of it is something you said to me the other day, Cody, is that we all need to take a look at ourselves and look at our education and look at our training and have an honest assessment about it. And figure out, okay, take what I'm teaching, I as a general statement, and compare it to what is considered the pinnacle of pre-hospital intubation training or airway management training.
Yep.
Look at the agencies that do it right. Look at the difficult airway classes. Look at everything that's out there. It's easily findable. It's not a hidden secret. We don't keep this stuff behind lock and door. We don't gatekeep the rest of EMS from how we do intubations correctly and airway management correctly, and figure out where the ones that are doing it really well, what are they teaching compared to what you're teaching or what you know, and then seek out what it is that you need to change. Because honestly, the stuff that's come out in the past 5 years is a little groundbreaking, like game changing when it comes to airway management. So,
well, I think you're hitting at one of my bullet points here. One of the big 5 things is there's too much focus on intubation and not enough focus on airway management as a system, as a whole approach to managing a patient. Of course, intubation is the gold standard. It's the definitive airway thing. But I mean, more often than not, and especially in the initial entry courses, they're pigeonholed into having to intubate everyone. Because I get it, like you need so many intubations to be able to log it to pass the course, and yeah, I get all that, but you have to teach the decision making as well. You have to build capacity as well as capability, particularly in airway management. I can't tell you how many times I've come behind, another course or another instructor, and the students have never heard of putting a nasal cannula on at flush rate and leaving it on for the duration, the no DSAT thing, even though I think that's pretty standard curriculum where we're operating. There's still in the initial entry, they're not being taught that. They're not being taught, good pre-oxygenation techniques. They're not being taught this entire system. They're being taught strictly blade in the mouth, bury it, pull out, cords drop, put the tube in. And we're letting students down because to lead to another point is we're allowing success with poor technique. And and this is a Weingardism. There's nothing more dangerous in airway management than allowing, in airway management practice and training, than allowing success with poor technique. The tube through the cords is the ultimate goal, but the ends doesn't justify the means. If you murder the airway getting in there, you got one shot. And if that tube comes out, or you have to do a tube exchange or something like that, and all that anatomy's been mangled from poor technique, then, you really didn't do anything. You increased morbidity is what you did.
Yeah. And to kind of hit on that, something that's not talked about, once again, references Mike, OK Medic. If you aren't following him, first of all, follow him, listen to him. He's got some good stuff. Back to his intubation episode from the other day. What we don't talk about is the amount of blades that come out with blood on them.
Yeah.
Okay. And that is something that's tracked in anesthesiology. That's not something that we track, but it happens a lot. And the most practiced people at it are still coming away with some airway trauma. So we need to make sure that we are doing our best to not contribute to that. But it's going to happen, and acknowledge it, but also put in place measures that are going to reduce that. And back to it, progressive laryngoscopy is one of those things, by the way. So
it is, and if you do it right, you won't.
Reduces. Yep.
If you do those things right, if you're practicing progressive epiglotoscopy or progressive laryngoscopy, and you should have already gotten the head positioned appropriately, which I was shocked to see that in one course that I did that was new for them, to open the collar and allow for neck mobility with manual in-last stabilization, of course. But, positioning the ear to the sternal notch and all these things, aligning the airway axis, doing all of these things to where you don't pry the airway open to see it. And they don't know that the more they pry, the more anterior that airway goes. And they're further pushing it out of their view. And there's a video on the AIME, AIME page on YouTube that shows exactly how that happens when they're doing progressive epiglotoscopy. They're walking the blade down the tongue and they don't have it seated all the way in the vallecula, and then they go to try to lift, and all they're doing, you can see that they're lifting the airway straight out of their view. And then 2 seconds later they walk it in, trigger in the vallecula, they trigger that ligament, they open that doorway right up. And folks don't understand that this is not a big muscle skill or procedure. You could do it with 3 fingers. It doesn't take a whole lot of mustard, but where they're taught these crazy techniques, like my pet peeve, I'm just gonna go there for a minute, is putting the forearm on the base so they can anchor the head down and see the air. Well, I've been doing that for 25 years. Like, well, that's wrong. You shouldn't have to do that. You should not have to do that. That means that your head's not elevated. You don't have the ear, and you don't have the head height. You don't have the head flex. You don't have the ear to sternal notch. You don't have the airway axis aligned if you're having to do that. And it's just allowing success with poor technique for 20 years is I think it's one of the greatest failures. If you're in an instructor role of any type, whether you're departmental, college level, this is something you do on the side, stop allowing the students to walk away with poor technique. And one example that I use to highlight this is, Josh, you ever been to like a shooting course? Like you had like a 2 lamb course or Pat McNamara course or whatever. And when they're
I mean, not
trooping
that high level, but yeah, I know what you're talking about. Yeah,
and when they're trooping the line, if you watch their videos or you go to their course and they're trooping the line, they're not looking at where you're shooting on the paper. They're looking at your technique. They're looking at your hand placement. They're looking at your head orientation. And it's so awesome. So my brother has been to a lot of these shooting courses too, and he'll tell you that some guy, I didn't know he was standing behind me, but he was watching me, and he said, "Hey man, you're overdriving with your thumb, and that's why you're missing your mark by this many inches or whatever." And he says, that I don't remember exactly what technique he told him to do it. And I think he had him buy what they call a gas pedal or something to put on his pistol, and fixes all his technique issues. And it's like, it didn't matter where he was hitting on the paper, and it doesn't matter where you're hitting on the paper if you don't have a good grip, if you don't have the fundamentals there. It doesn't matter if you sink a tube through the cords, if you bust teeth, cut lips, traumatize the airway while you're doing it. But I wanted to circle back to something that we kind of hit on in that first few minutes to move on from the topic, was because we could do that all day. We can pick apart all the little nuanced things of just poor procedural skill. But the one big one is the unrealistic scenarios thing.
yes.
Unrealistic scenarios, and it's one thing to have them on the table to practice the getting used to the blade and getting used to the build the muscle memory. That's perfect. That's great. That's what some of that training is designed to do. But I'm going to use this example. You know where I'm going with this too. Taping the thread the head of the bottom of the desk to practice intubation, to make it hard. It doesn't make good practical or tactical sense. Which is there's another paper just came out of the JSOM, Doc Loria and Andrew Fisher, and I forget the third author on the paper. They specifically address this thing of just being ridiculously unrealistic with training scenarios. Like, do you really need the lights and the smoke and the loud noise and just all these extra stressors on people who are just learning the skill to begin with? Let's stress them out. That'll make them better. Actually, no, it won't. You're going to build training scars. You're going to build anxiety triggers. You're not going to train them. You're not going to give them any confidence whatsoever in the skill. And
it goes back to crawl, walk, run.
Yeah,
that is a huge training euphemism in the military. I've seen it in the fire service.
Undefeated.
If you're going to add these big extra steps, you have to build the fundamentals first. You have to build the basic stuff first. And it's almost sometimes these things, when we're talking about EMS education, some of this extra stuff needs to be left till CE. Quite honest. Mm-hmm. They do not need to be initial education. We've talked about this before with other things when it comes to 12 leads. But there's just stuff that, it is, you can argue it's important to know, but at the same time, are we losing the most basic and the average understanding of what we need to do to accomplish our job? And adding the extra stuff sometimes is not, the juice is not worth the squeeze, quite honestly. You talk about putting the thread of the head underneath the desk. 17 years doing this. Cody, you're right around that, maybe 20 years.
Easy.
Wow.
I got
you got a little more time on me. But I never seen or heard of a scenario in real life that these crazy thread the head upside down in the dark underneath the table, all underneath this stuff, was that even applied? Never.
Nope. Never. Not one. Excuse me. Not once. Not ever. I think those types of, what I call those, man? I call those shoot, no shoot scenarios. Like you do in certain places where you train a shoot or no shoot scenario, meaning that you set up a problem scenario for the student, and they walk in and they need to be able to identify, this is an intubating scenario, or this is a not intubate scenario. And I am all about it. Trash the sim lab and create a big pile or create a disaster if the goal is for them to go in there and say, I'm not going to intubate. I'm going to drop a supraglottic or a BLS airway. Then we're going to, and as long as I'm ventilating and oxygenating, we're going to extricate and then I'll intubate. If you're reinforcing that kind of decision making, you're doing it right. I think you're doing that perfect. If the sole goal is to intubate upside down, which I've like you said, I've been doing this a minute. I would never do that. I would put a supraglottic in their airway, or I mean, if they truly had, there was a colleague of mine who had worked a rollover, and the patient was, their face was smashed, and they had no airway whatsoever, and the supraglottic didn't work. They had to crack upside down. Cool. That's the only time in 20 years you're going to do that. Right. The only time. So write that down. Make sure that chapter is already written for when you write your memoirs, because that's the only time you're going to do it. I think that, again, it comes down to decision making versus skill, like this sky hooking or tomahawk style stuff. If you're in that situation where you're having to deviate from the norms, from the proven norms, that's not an intubation. That's not a shoot situation. That's a no shoot situation, and you need to go to a backup alternate approach, right? Like forcing intubation scenarios are not good training reps, especially for new folks. If you want to turn the lights out and you want to smoke up the room and stuff like that because you're wanting to add some stress, I think that works later on, like for a new paramedic class. That's at the end of the course, when you're doing ops and terrorism response and you're doing that stuff and you're trying to keep them engaged in the course. I think that's perfect for that. But 3 weeks after they just learned how to intubate is probably not the best time. And for the instructors out there who are building these scenarios, I want you to ask yourself 2 questions. The first one is, have I done this for real in the field? And number 2 is, would I make that decision that I'm asking them to make? Would I make that decision in the field in real operational context? And if your answer is yes to that, okay, then you obviously have some teaching points that you're trying to get across. If your answer is no to that, skip it. Put the guy on the floor, have them practice intubating from their knees, not on their belly. And just a tip: if you're intubating from your belly and you elevate the head of the bed appropriately, can't see anything. Just wanted to put that out there.
Yep.
What do you think, Josh?
So, no, that's completely true. Not to mention, I don't want to be a war story here, but I can't think of many situations where I had the complete room to lay my almost 6 foot long body down at the head of my anywhere from 5 to 6.5 foot patient and not have issues. So, elevate the head, drop down on your knees and use DL or VL, whatever it is that your service has first pass, and go for it. But moving on to other points, because I know we've beat that one, and we've also jumped off that one a couple times.
The last one is, I'm probably going to step on some toes with this one, but we do a terrible job teaching airway assessment. And here's what I mean. Every paramedic should have heard Lemon before, and probably the newest paramedics have heard the Heaven criteria before. And that's one piece of airway management. That's one assessment for difficult DL or VL. But we do our students and our trainees a complete disservice when we neglect to teach them how to assess for difficult BVM, for difficult supraglottic, for difficult crike, because we operate as if those things are absolutely going to work and bail us out. And that, my friends, is probably one of the gravest mistakes that we're making in airway management training. And it's in the literature, right? The three easiest ways to lose an airway management case is no assessment, not documenting your assessment findings, and not acting on the assessment findings. So, failing to plan and planning to fail, that kind of thing. That's people lose money and lose licenses, and patients die that way.
Yep.
And it goes back to kind of what I just said go ahead.
I think a part that plays into that as well on your airway assessment is considering that the quote-unquote classic approach to airway management, or the stepped approach to airway management, is how it must be every time. That we start with a BVM, an OPA, NPA. Then we assess. Some places say, okay, the next step would be supraglottic. The next step would be an ET2. The next step would be a crike, and the crike is the last step. This is a fluid thing. There are those that, from the get-go, are going to need an SGA. There are those from the get-go that are going, we're going to try and BVM with an OP and NPA. That is how we all start. But it's from that point that we determine what is going to work best for our patient. And it's part of the assessment. Looking at your patient and taking an honest-to-God assessment of, should I jump to certain things early, or do I think I have, whatever it is, an indication that this is going to work correctly? Okay. And I'm a little bit on a soapbox lately about the crike. We teach crike is like the last step, and I'll say I'm at fault for this, for even putting into the atmosphere, the kind of almost the manifestation of this is that this is such a rare skill. None of us do it. If you meet the medic that's done it, pick their brain, because it's probably the one time they've done it. It's their one chance to get someone's experience from it and stuff. There are patients where this is your first line airway. From the get-go.
You walk up and you're at the end of the algorithm already.
Yes. And that's where the assessment comes in. Looking at the patient and determining, can they accept an ET tube, an SGA? Is BVM going to be just fine? And then as we go through these steps, when things aren't working, why are they not working? I don't know if I've talked about it. I had a patient back day after Christmas last year. Unfortunate major TBI via head-on collision. And when we were BVMing, we had a C collar on, and we were getting no oxygenation, no ventilation. We were getting resistance. And what was happening was that the collar was actually pushing the chin up and occluding the airway. And so it's okay. We've got a patient that definitely needs to be collared and ported due to mechanism and an injury we thought was present, but it wasn't actually. But how do we still maintain this stabilization, but provide oxygenation and ventilation, which is more important? Ended up doing, I think we used a blanket and made a C collar out of a blanket. That is a little bit of an old school teaching. I don't know if they teach that still on how to make
the old horse collar
out of a blanket or anything. But that's what we went with. Yeah, that's what we end up going with, and that's because we determined something wasn't working properly. So to continue with the assessment, Cody.
Well, yeah, and to build on that, we sometimes make the mistake of stopping at physical difficulty with the airway. There's two more areas we have to assess or be aware of, especially if you're an RSI shop, and that's physiologically, are they prepared or optimized to handle the procedure? It's one thing. It could be a walk in the park, easy peasy, no anticipated difficulty airway, which is nonsense. They all have some degree of difficulty. And, the patient is hypoxic and hypotensive, and you've got to resuscitate prior to intubation. resuscitate, then intubate, and then finally after that, and we know, not to beat a dead horse, we know that intubating hypoxic and or hypotensive patients just is the outcomes data, and the morbidity mortality is astronomical with that. The last one, or the last assessment, is contextual, and this goes to what we've kind of been talking about, of teaching students how to assess the context they're in. Would I make that decision in the field? Is this the right time to intubate, or can I, or should I do something less invasive, supraglottic, and extricate and then intubate? Or did I walk up to the patient and I'm at the end of the algorithm already, and I've got maybe a little bit of a delicate situation, like you've got you're there with an engine crew that maybe doesn't see it that way, or you're there with a partner, you're a flight team, and you're in somebody else's house, you're in somebody else's hospital, and they don't see what you're seeing, and you've got a difficult context, and that's where the psychological difficulty, but we call it a contextual assessment, but there's psychological difficulty there as well, that you have to mitigate. You have to do something about the human factors.
And since we're talking about airway management training, I'd say this is up there with one of the more difficult things to simulate in a lab. Okay. All of our mannequins, for the most part, are what look like healthy individuals. Okay. We don't have, I haven't seen really good sims that are obese, that
they don't have a
you
six
can look
pack,
at
man.
and you're like, well, that's a no. Yeah, that's a no neck. I'm going to have difficulty manipulating, definitely going to need ear sternal notch, whatever it is. We don't have great, at least I haven't seen them. If you're someone out there that has these mannequins, please hit us up. I'd love to see this. I'd love to send it to my academy and be like, hey, let's figure this out. Mannequins that would, if you walked into the patient, you'd be like, that's a crike. Very rarely do we have any mannequin that's going to assess that. So why am I saying this? For you FTOs out there, preceptors, this is when you're going to see these things. This is when the student's going to see these patients that you're like, so what's our proper course of action here? Because this is not, six-pack sim man that you're going to get a great bag balance fast seal with NPA, OPA. You're going to get great oxygenation. Mm-hmm. Oh, and then you're going to have a clean airway. That, hey, the difficult airway simulators, sometimes they have, floppy epiglottises, or, maybe some abnormal anatomy in the upper airway. You can simulate blood, you can simulate emesis, saliva, all that stuff. But it's difficult to simulate some of the stuff we actually see in the field. And that's where it's on, like I said, FTOs, preceptors, to talk with your student, be like, what are we going to do here? Not just be like, hey, they need airway, figure it out.
Yeah.
This is, time to teach, time to act at the same time.
To that point, Josh.
But if you guys can figure out ways to simulate that in the lab, that's great. I recently saw one during a trial I did. It's actually probably one of the better crike simulators. It was in-home made by this company. But it actually simulated bleeding and adipose tissue. Usually your crike simulator is either, a very bare pig's neck, or it's the mannequin neck that has the piece of rubber strapped around it with a piece of tape underneath over top of the brachithyroid membrane.
Mm-hmm.
That's it. But this one, actually, I like that, and I actually have been meaning to reach out to them and be like, hey, is there any way we can get those?
Yeah.
But
to that point, Josh, there's a company out there, they're called Life. They make the LifeCast mannequins, the super hyper real, like the sex doll version of medical simulators. Yeah. And we talked to these guys, kind of a funny aside story, but they were approached by that industry because they're so realistic, and they were like, no, we can't scale to the size of that demographic that would be utilizing it. But anyway, so the same company, they make very lifelike simulators. They have super elderly patients that have the same, the faces, the anatomy, everything looks the same. They have a Down syndrome simulator out there, and we can, that's a nightmare patient in my mind to have to intubate, or to have to manage their airway. They have little bitty tiny kids, babies that are so hyper realistic. You're gonna have nightmares after that training.
Yeah.
Thanks. That's LifeCast that does that. And one thing that I do, and have done for some crike training, is I'll take Fred the Head, and I'll buy a Halloween mask with a nice cape on it that'll actually cover up the neck, and you can slide these little I got one right here. You can slide these little 3D printed crike trainers up underneath that cape, and they can cut that mask all day long. You just put you can make another cricothyroid membrane, and all you have to do is just go up underneath the mask and tape it along the margin, so that they can cut it again and cut it again and cut it again until they've actually just mangled the mask and you can't use it anymore. Freddy Krueger mask goes over really, really well. We might have some pictures. We can put that up on the we can put that up on the Instagrams, and I'll show you guys that trainer.
Yeah.
But I guess, Josh, that's the world according to us as far as some training stuff that we've seen out there. Do you have any closing thoughts?
Yeah. I think some of the take-home points here are: look around at what other agencies are doing. Take a look at what the high-performing agencies do. Okay? I'm not talking about big agencies. I'm not talking about small agencies. If you're at least somewhat in the know about other EMS agencies, you know the ones that are doing the cool stuff, the ones that people want to work for, the people that, people are always sharing their stuff. Reach out to them. Find out how they're teaching their medics how to properly manage airways, what they're using, mannequins, scenarios, high fidelity, low fidelity, whatever it is. And then engineer your scenarios to do that. You can do that both at the initial education level, the continuing ed level, and in the station. Firefighters, EMTs, paramedics are the kings and queens of ingenuity when it comes down to it. A lot of times, figure out something that works best and take those best practices that other places are doing, factor it into your training, and then factor it into your care. I think I said it to someone the other day. If you properly train, do the stuff properly in real life, in reality, like on the actual calls, you will find that you enjoy this job a lot more, because you will see positive outcomes. You'll see good care. You'll see the stuff that, when you were taught in initial training, hey, when you do this, these things get better, or this happens, things get great, and you save lives, and whatever, you want to say, whatever cliche, corny phrases, whatever it is. If you do the job correctly, if you train correctly, you'll see good outcomes, positive outcomes, and you'll actually enjoy this job a lot more. Just saying that kind of comes maybe from some personal experience. I've been asked before, how do I still love this 17 years later when all we talk about is people getting burnt out in this profession? Not saying I do everything right, but I know I do some stuff right, and I still love this job. So
you've sought some training that made you better, though, right?
Yeah, there's definitely a lot of training involved there. If you're also looking for ways to get better with training and understanding yourself, become a trainer. Even if it's just, being the back of the classroom adjunct instructor, listening to the ones that teach it. And then you eventually work up to teaching lectures and teaching skills and stuff like that. It does make you a lot better. You understand the material better, you understand techniques better, and then hopefully you are teaching somewhere that is incorporating new and burgeoning techniques.
Yeah, I can personally attest to that one, man, with a new training venture that I've been included in, just by sheer luck. But yeah, you find out how deep you are when you're teaching at that level. And like, oh my goodness, it's nuts. But to sum this thing up for everybody, all right, so we talked about really five issues or 5 areas of interest for you to beef up your airway management training program. Number 1, don't teach what you were taught the way that you were taught. Read, get current, practice, and then teach from those lessons learned. Number 2, eliminate the unrealistic training scenarios. Eliminate it. Unless you're using it in a very prescribed purpose for decision-making training or decision-making practice. Otherwise, they really don't have much of a place in your training program. Number 3, do not allow success with poor technique. Make your students do it right. Make your trainees do it right. I don't care if they've been doing it for 30, 40, 50 years or longer than I've been alive. It doesn't matter. It doesn't matter if you're doing it with poor technique. Poor technique hurts patients. Just remember that. Number 4, focus on airway management as a system, not as the singular skill of intubation. We have a huge toolbox in this area for a reason, and there's a few different ways to skin this cat. So focus on the system as a whole and how to implement the system that you have, or build the one that the progressive agencies have and replicate their success with it. And then finally, number 5, for the love of all things sacred, teach a deep airway assessment and make sure that you have identified as much difficulty as you can, whether it be a physically difficult situation or scenario, or it's a physiologically difficult situation or scenario, or a psychologically difficult situation or scenario. And you need to have some pre-planned responses before that, because here's the bottom line, folks. Success in airway management happens in the weeks and the months prior to you standing over somebody that needs their airway managed. The success of that encounter is built in the weeks and months prior. That's all I got for you.
Well, I hope everyone took away something from this. I know we've talked about some of this before, and then Cody over at Ordinary Ops Medic has talked about it as well a bunch. Make sure you're following us on Instagram. Make sure you're following Ordinary Ops Medic on Instagram as well, where he will elaborate on these things even more over time, along with other great training and education techniques.
Thanks for
but
the love,
wherever
bro.
you are, good morning, good afternoon, good evening, good night. And see ya.